Welcome to this video describing the management of anorexia, cachexia, constipation, and diarrhea in pediatric palliative care. Our learning objectives for today is with respect to pediatric patients with life-limiting illnesses. After watching this video, you should be able to assess and manage anorexia and cachexia, constipation, and diarrhea. Let's look first at anorexia and cachexia. We have to remember that eating has a high importance for parents and families and is very culturally, emotionally, and religiously significant for many people. This means that when a child stops eating, there can be a huge amount of distress for the family. Let's define a few of the key terms. Anorexia refers to a loss of appetite or poor caloric intake, whereas cachexia refers to a metabolic syndrome which is characterized by loss of muscle with or without a loss of fat mass. Anorexia cachexia syndrome involves anorexia with involuntary weight loss, tissue wasting, and weakness. And we see this in the setting of chronic illness. For cachexia, in adults with advanced disease, this has been fairly well studied. They've looked at the disease and how a number of different factors influence it, including a number of the things you see here: host cytokines, inflammatory processes, the anorexia, and this all leads to cachexia. This is sometimes referred to as primary cachexia, which involves this complex cascade, as you saw, of metabolic, hormonal, neurotransmitters, and physiological factors. And as we mentioned, this is most common in individuals with solid tumors, HIV/AIDS, and chronic lung disease. We do see it in children with the similar underlying conditions. Other common causes of anorexia in pediatric palliative care include chemotherapy or radiation, so oral problems such as dysphagia, dry mouth and mucositis, and swallowing problems, gastrointestinal reflux, bowel issues including severe constipation, obstruction, organomegaly, malabsorption, and chronic inflammation or infection. Severe pain as well as anxiety and depression can also lead to anorexia. In our initial assessment of anorexia and/or cachexia, we should focus on identifying reversible causes. Look at food intake and weight loss to see if these can be addressed. Look at symptoms that may be unrelieved, such as gastrointestinal symptoms, dyspnea, fatigue, or even pain. Look at psychological or emotional issues such as depression and anxiety, which could lead to poor oral intake, which could be identified and reversed. And look at medications, which may be suppressing the child's appetite. Communication is a really important part of our management for anorexia and cachexia. Families need to understand that these symptoms may occur, and they should be prepared for the loss of appetite and the decreased oral intake, which accompanies children who are progressing towards the end of life. Some of the treatments we can counsel families to provide include using smaller meals of favorite foods to encourage the child to eat, maintaining a comfortable environment, avoiding unpleasant odors, and providing good mouth care so the child feels well enough to chew and swallow if they can, and eliminating any medications which may be suppressing appetite. The challenge of treating anorexia with medications is that there are very few medications that have this indication, and most of them have significant side effects and limited evidence to support their use. Some of the medications which have been proposed and been reported in the literature include steroids, but these have a number of other side effects, and so the risks may outweigh the benefits in many cases. Megastrol, which is a synthetic progesterone analog, which has been used in small trials but carries a risk of adrenal suppression, so is not used widely. And cannabinoids have been also proposed as a strategy for anorexia treatment. However, there's no evidence to support this use in pediatrics. If we look at the communication around anorexia at end of life in more detail, we need to explain to families that food and water are generally avoided by children when they're in the end of life phase, similar to how all of us don't feel like eating or drinking all that much when we're feeling very unwell. We should encourage parents to focus on letting the child choose what to eat and drink to avoid any pain or suffering, emphasizing the importance of the child's comfort, not forcing them to eat. As the child gets weaker, then swallowing may become more difficult. And if the child's forced to eat, they may choke or aspirate. This could lead to infection and a lot more discomfort and distress for the family if they see the child choking. So, how do we respond to the questions like this? The parents may ask, if we don't feed her, she's going to starve to death. She's no longer drinking anything. Won't she get dehydrated? We need to share with families that there's not evidence that artificial feeding or hydration, meaning by IV or NG tube or gastrostomy tube, prolongs life when patients have a prognosis of days or weeks. There is also no evidence that giving IV fluids to patients in the last few days or weeks of life reduces the sensation of thirst or hunger or dry mouth. In fact, these are very uncommon sensations in people who are dying. Again, to respond to these questions, we should share that as a child nears the end of life, they need less fluid. Their body is naturally going into a shutting down phase, and there's reduction of their renal function. We know that urine output naturally decreases at the end of life. And the best things to do are to provide appropriate mouth care, moistening with a cloth with water, and gentle toothbrushing. Families may be very worried and want to continue with artificial feeding by NG tube or with IV hydration. We can counsel them about some of the risks of these things. For feeding, there could be a risk of reflux and aspiration. For both feeding and fluids, there's a risk of edema and ascites. And this can lead to respiratory distress if the child develops pulmonary edema or significant oral pharyngeal secretions. And all of these could lead to discomfort, dyspnea, and pain for the child. And this is why we don't recommend artificial feeding and artificial hydration in the last days or weeks of life. However, sometimes we have families who are very insistent, and we may need to do a trial of hydration to ensure that they feel that we have offered and tried all the treatments which may be appropriate. We need to explain that there can be risks, that the child could actually become worse. They could have more trouble with their breathing. They could have more secretions, which they're not strong enough to cough out themselves. And if we do start IV or NG feeds or fluids, we should explain that if the child's symptoms don't respond to the fluids, then we should stop or wean the artificial hydration or nutrition. So it's key to identify the symptoms which you are actually treating with the hydration before you start it, and then to measure the success of your treatment against those. And if you don't see success, that's a reason to reduce or discontinue the fluids. Let's go on and talk about constipation. We need to assess this with the following questions. Are the stools difficult to pass? Is the frequency of stools at the normal for the child, or are they passing them at a different frequency? Are the stools smaller than usual or harder than usual? And if there's a bowel regimen in place with stool softeners and laxatives or other items, is this effective? In pediatric palliative care, here are some of the most common causes of constipation. Opioids and other medications, including anticholinergics, antiemetics, anticonvulsants, antidepressants, and antibiotics have all been implicated. Metabolic derangements, including hypercalcemia, hypokalemia, hypothyroidism, and uremia may also be present, and you can consider these investigations if appropriate for the goals of care of the child. Other common causes we see in pediatrics include neurological impairments. These children always seem to have delayed and slowed gastric motility and gastrointestinal tract motility. Immobility or being bedbound leads to slowing of peristalsis. The diet, if it's reduced in fluids and food, will also result in less stools, and these can be harder if the fluid amount is reduced. Sometimes we have children with abdominal tumors, and this may compress directly on the gastrointestinal tract and lead to constipation. And there can be practical barriers which prevent children from going to the washroom, including shared toilets on wards, or children who aren't able to ambulate to the toilet or aren't able to be positioned if they're weak or they can't stand or they can't sit to go to the toilet. Let's look a little bit more at the mechanism of opioid-induced constipation, because this can be quite frequent in our population. Opioids induce constipation through three main mechanisms. They reduce bowel motility, they reduce bowel secretions, and they increase colon transit time, leading to more fluid absorption, leading to harder and smaller stools as more fluid is absorbed from the colon. When we think about the pharmacological management of constipation, we want to think about 5 different types of treatments we might use: stool softeners, stimulant laxatives, prokinetics, opioid induced agents, which are opioid antagonists, and enemas or suppositories. Let's look at each of these in a little more detail. Stool softeners provide mush, but they don't push the stool along any faster. They draw water into the bowel by an osmotic effect. This can cause some cramping or pain. The most common examples in this category include lactulose, products containing sorbitol, and products containing polyethylene glycol, which in some countries is called PEG 3350. I note that there's no evidence to support the use of docusate sodium in palliative care or elsewhere. So we would recommend against using this medication, which has been marketed in the past as a stool softener. First, the second class I will talk about is stimulant laxatives. These work by stimulating the myenteric plexus. So this theoretically induces increased bowel motility. However, we should avoid these if there is a suspicion of GI obstruction or impaction, because they will just be pushing against a fixed obstruction, which will be painful. These are generally best used in combination with stool softeners. The stool softener softens the stool, the stimulant laxative pushes along the nice soft stool. The most common medications in this category include senna and bisacodyl. Prokinetics are for situations where you suspect gastrointestinal hypoactivity. And the examples in this category include metoclopramide, domperidone, and erythromycin. Suppositories or enemas include suppositories of glycerin or bisacodyl, and enemas, which typically we have fleet enemas, which are consisting of phosphate, and microlax enemas, which consist of a surfactant. For opioid-induced constipation, we know that opioids are active at the mu-opioid receptors in the GI tract smooth muscle, and we want to block this action to relieve those mechanisms which are causing the constipation. There are 2 medications which are opioid antagonists, which can be used for this purpose. Methyl naltrexone is a selective GI tract opioid mu receptor antagonist, and the dosing is given here. It's generally effective very rapidly, within 30 minutes. Naloxone is orally administered, and there is also some anecdotal evidence for using IV infusions continuously and has the same effect of opioid antagonism. However, if the patient is having pain, the problem with naloxone is it will also antagonize the central effects of the opioids, which are relieving the pain. Let's look lastly at diarrhea in pediatric palliative care. There are some common causes that we should think about on our assessment. Constipation with overflow diarrhea is incredibly common as a cause in pediatrics. We may want to think of infectious causes or antibiotics as causes. Additional but less common causes include malabsorption, which may be more relevant in patients with cystic fibrosis or other diseases associated with GI tract malabsorption, such as Shwachman-Diamond syndrome. Medications can also cause diarrhea at times, radiation, and laxative overuse. The treatments that we should think about should address the underlying cause if possible. Often we have to stop certain treatments which are causing diarrhea. There's also indications for specific directed therapies for certain types of life-threatening diarrhea or certain causes. If the child has a bacterial or parasitic infection, we should obviously use anti-infective agents targeting that. For short gut syndrome, we sometimes use a product called cholestyramine. And for cystic fibrosis and other diseases where pancreatic enzymes are insufficient, we recommend replacement of pancreatic enzymes. Other considerations for treatment include management of dehydration, which is usually secondarily caused by the diarrhea, and we can use the following medications as well. Anti-motility agents such as loperamide, which is actually an opioid, which has very little pain-relieving ability, but does slow down gastric motility. So basically gives you an opioid-induced constipation, which is what you want in this situation. Anti-secretory agents, which reduce secretions into the GI tract, such as octreotide, and probiotics have also been proposed to be effective in this situation. In summary, for today's video, we've talked about anorexia and cachexia. These are common at end of life. We need to support families to understand what is happening to their child, encourage them to focus on good mouth care and maintaining a calm and supportive environment for eating, but not forcing their child to eat when the child does not feel like it. For constipation, we talked about a number of different types of medications which can be used, including stool softeners, stimulant laxatives, prokinetics, and opioid antagonists. And for diarrhea, we mentioned about the causes and the supportive treatments.